Welcome to the deep dive. Today we're really digging into something critical, from basic geriatric nursing, chapter 13 specifically. It's all about coping in stress, particularly how it hits the older adult population. It's more than just worry, isn't it?
Oh, absolutely. Stress in later life often stems from loss, and it becomes this potent physical reality. And that's really our goal today, to pull out the essential clinical insights from this chapter. We need to understand stress, how it, physically and mentally changes older adults. And importantly, what can we actually do about it? What are the practical nursing strategies?
Okay, so let's start with the basics. What exactly is stress, according to the source?
Well, fundamentally, it's how we react when we face a threat, real or just perceived, or any big life change. And a key point the chapter makes is that stress is cumulative.
Hmm.
Lots of small stressors can basically add up to have the impact of one huge crisis.
Right, it's not always the one big thing. There's a difference between good and bad stress.
Exactly. Dr. Hans Selye talked about this. There's eustress, which is positive stress.
Hmm.
Think planning a wedding or maybe starting a new hobby in retirement. It takes energy, but it's generally positive.
All right.
But what we're usually concerned about in healthcare is distress. That's the negative kind, the draining type, that forces the body to adapt and can, well, lead to health problems.
And Selye also gave us that model, the General Adaptation Syndrome, GAS. It describes how the body predictably reacts.
Yeah, that's his classic model. It outlines this universal physiological response. There are three stages.
Okay, walk us through them.
So first is the alarm reaction. That's your basic fight or flight. Adrenaline kicks in, heart rate goes up, body's ready for action.
Got it. Primal response.
Then, if the body can handle the stressor, it moves into the resistance stage. It tries to, get back to normal, find balance again.
But it's that last stage we really need to focus on with older adults.
Precisely. Stage 3 is exhaustion. This is where the body's energy reserves are just gone, depleted.
And the book says this stage actually mirrors the wear and tear of aging itself.
It does. It's like an acceleration of that process. When the body hits exhaustion, its ability to fight off illness plummets. And in really severe, prolonged cases, the source notes, it can even lead to death.
Wow. So chronic stress literally ages the body faster.
In essence, yes. And for older adults, what's usually fueling this exhaustion, it's loss. Repeated, significant loss.
And we can actually see the weight of these losses. There's a scale mentioned.
Right, the Stokes-Gordon stress scale. It quantifies the impact of different stressors common in later life. And looking at it, it really forces you to reconsider what counts as major.
Yeah, the examples given are powerful. The top-ranked ones aren't like global events. They're deeply personal. Death of a son or daughter, unexpectedly, that scores 100. Just maximum weight.
Incredible.
Decreasing eyesight is 99. Losing the ability to get around that mobility is 96.
Things we might almost take for granted as part of aging, but the impact is immense.
And even giving up a driver's license, which seems maybe administrative scores is 76. That's a huge marker for loss of independence.
It is. And these chronic psychological loads, they trigger immediate physical responses, which of course makes any existing health conditions much worse.
Okay, so let's get specific about those physical effects. What happens system by system when someone's under chronic stress? Well, cardiovascular is a big one. You see the classic signs. Pulse and blood pressure go up. Hands and feet might get cold, clammy.
There's a higher risk for angina, irregular heart rhythms, even heart attack or worsening hypertension.
And blood sugar, too.
Yes. The body releases stored glucose for energy. Good for immediate action, but really dangerous for older adults managing diabetes.
What about the gut? That seems really sensitive to stress.
Very much so. Digestive enzymes decrease. This can cause loss of appetite, ulcers, and it's tricky because it can lead to either constipation or diarrhea. It varies.
So unpredictable digestive issues.
Right. Then respiratory breathing rate and depth increase, sometimes too much, leading to hyperventilation.
Causing that tingling or dizziness.
Exactly. And musculoskeletal, you get increased muscle tension, those awful tension headaches, maybe teeth grinding. Basically, every system feels it.
If the body's under siege like that, the mind must be too. The chapter talks about cognition. Mild stress helps focus.
Yeah, a little bit of stress can actually sharpen your alertness, make you more focused. But when stress becomes severe or chronic, cognitive function declines, often rapidly.
How does that look?
The source uses the term tunnel vision. The person just can't see the big picture anymore. They struggle to solve problems. They might make irrational or impulsive choices or just freeze up, unable to decide anything.
In memory.
Definitely affected. Chronic stress actually causes physiological changes in the brain structure that impair memory function. It's not just being distracted, it's a real impact.
Emotionally, what are the warning signs?
Well, things like fatigue, constant tension, anxiety, being really irritable. Poor self-worth is common too, feeling overwhelmed. And in severe cases, you have to be alert for signs of major depression, hopelessness, preoccupation with problems, and crucially, any talk of suicide. That brings us right to depression. The chapter is very clear. It's common, but not a normal part of aging. Absolutely critical distinction. It's often missed precisely because it's so common, and the symptoms can look like other things.
Like what? What are the mimics?
Things like chronic pain, changes in appetite, sleep problems, even behaviors that seem like early dementia. It's easy to misattribute.
So clinically, what's the benchmark for diagnosis?
We need to see key symptoms like a persistent low mood, feeling hopeless, losing interest or pleasure in things most of the day, almost every day, for at least 2 weeks straight.
And treatment isn't just about feeling better short term.
No, the goals are bigger. Reduce symptoms, yes, but also lower the risk of it coming back, improve quality of life, and actually improve their overall physical health status, too. It's all connected.
Okay. Now, sometimes people try to cope in ways that aren't helpful. Self-medicating, which often means substance abuse.
Yes, and the chapter points to alcohol as the most commonly abused substance among older adults.
Why are they more vulnerable to alcohol's effects?
Several reasons. Physiologically, as people age, they tend to lose lean muscle mass. Their liver function changes, how they metabolize alcohol, and their nervous system becomes more sensitive. Meaning, even a small amount of alcohol could have a much bigger, more detrimental effect than it would have in a younger person. The safe limit really decreases.
And detecting this abuse is hard, just like with depression.
Very hard. Because the signs, things like falls, confusion, sleep changes, maybe worsening hypertension or bone density issues can easily be blamed on just getting older.
So as a provider, you need a high index of suspicion. If you see falls, sudden confusion, you should consider alcohol.
The source strongly suggests that yes, because it's so easily missed, and there are patterns too.
Patterns of abuse.
Yeah. You have long-term abusers who might show more classic signs of alcohol use disorder, but then you have late-onset abusers,
Starting later in life.
often in response to a specific stressor retirement, death of a spouse, a major move. They might have fewer physical symptoms initially, less chance of severe withdrawal, but they're very likely to drink alone, hidden at home.
Are there specific groups more at risk?
The chapter mentions older men, perhaps coping with financial stress or loss of status, and also, significantly, older widows who live alone.
Okay. Before we get into active coping strategies, the book mentions defense mechanisms, those unconscious things we do.
Right, like repression, pushing thoughts away, denial, refusing to accept reality, rationalization, making excuses, projection, blaming others, sublimation, channeling impulses constructively.
He's always bad.
Not necessarily. They protect us. They only become dysfunctional, the chapter notes, if someone relies on them too much, using them to avoid actually dealing with the stressor itself.
So moving beyond those unconscious defenses, what about conscious coping? The book divides styles.
Into two main types, yeah. First, there are problem-focused strategies. This is where you try to change or eliminate the stressful situation itself. You tackle the source.
Okay, direct action.
Right. And the second type is emotion-focused strategies. Here, you don't change the situation, but you change your response to it. You manage the feelings it causes.
Like learning relaxation techniques if you can't change the stressful environment.
Exactly. And the key takeaway here is the difference between being proactive versus reactive.
Innate.
Taking a proactive stance, actively choosing a response, trying to control some aspect of the situation, even if you can't fix everything, helps maintain a sense of control. Being purely reactive, just letting things happen to you, increases stress. Control matters.
That makes sense. And there's specific techniques people can learn, non-drug approaches.
Definitely. The chapter highlights several. There's progressive relaxation, systematically tensing and then releasing different muscle groups, helps you identify and let go of physical tension. Then imaging or visualization. You create a detailed mental picture of a calm, peaceful place. It's like a mental escape.
And meditation.
Yes, both concentration meditation, focusing on breath, or a mantra and movement meditation, like gentle yoga or tai chi.
The chapter also mentions geriatric massage specifically. How's that different?
It's modified, usually shorter sessions, maybe 30 minutes, to avoid overtiring the person. It's gentler, but still very effective for improving circulation, easing pain, reducing anxiety and depression, and helping with sleep.
Okay, so bringing this all into a nursing context. The source talks about specific nursing diagnoses related to stress. One is limited coping ability.
Right. This is when someone is really struggling to identify what's stressing them or how to respond. You might hear them say things like, I just can't cope anymore, feeling hopeless.
What are the key nursing actions then?
It starts with the basics. Building trust is huge. So, continuity of care, having the same nurse assigned as much as possible is really important.
Consistency, yes, and making sure basic needs are met. Good nutrition, enough rest, managing pain effectively. Unmet physical needs are major stressors. And encouraging them to talk.
Absolutely. Create a safe, non-judgmental space for them to verbalize their feelings, their fears, and help them identify coping strategies that might have worked for them in the past. Tap into their own history of resilience.
Okay. The other major diagnosis mentioned is disrupted living situation. This sounds like relocation stress.
Exactly. It's the stress tied to moving home to hospital room to another room, or the really big one, home to a long-term care facility.
When is that stress the worst?
It's most intense when the move is sudden, unexpected, or especially when the person feels they had little or no say in the decision. That loss of control is devastating.
And how might that manifest? What are the signs of poor coping with a move?
You might see intense feelings of powerlessness, maybe increased dependency, or the opposite hostility, anger, refusing care. Withdrawal is common too, sometimes even physical regression, like someone who is continent suddenly becoming incontinent.
Wow. So interventions have to focus squarely on restoring some sense of control.
Absolutely. That's the core principle. Be open. Be honest about why the move is happening. Encourage them to talk about their anger, their fears. Don't dismiss those feelings.
To involve them.
Crucially, yes. Include the older adult in care planning and decision-making whenever possible. Even small choices, what to wear, when to bathe, can give back a sense of agency.
And familiar things from home.
Vital. Encourage bringing personal possessions, photos, familiar objects. These things ground them, provide comfort, reduce confusion, and reinforce that sense of identity and belonging in the new place.
Consistency of caregivers matters here too, right?
Yes, maintaining that continuity helps build trust and security during a very insecure time.
And if the move is planned, say from home.
Preparation is key. Allow plenty of time. Arrange visits to the new place beforehand, if possible. Let them participate in sorting belongings. Anything that makes the change less abrupt, more processed, helps reduce the stress.
So wrapping this up, it seems the big message from this chapter is that understanding stress in older adults means understanding loss, and that our best tool, clinically, is finding ways to support their sense of control.
That really sums it up. We have to see stress not just as emotion, but as this powerful force tied to loss, and prioritize strategies that empower the patient.
Before we finish, any final thought for our listeners to take away? Something provocative.
Well, connecting it all back to physiology, remember that chronic stress, with its high cortisol levels, directly impacts the immune system.
Making people more vulnerable to illness. Yes, more susceptible to infections. But think about this. It can potentially even blunt their response to vaccines. Things like the flu shot, pneumonia vaccine, maybe even COVID boosters. Their stressed body might not be able to build immunity as effectively. That's quite a thought. Stress is a direct barrier to the effectiveness of preventative medicine.
It highlights just how deep the connections run between mind, body, and health outcomes, especially in this population.
A really crucial connection to understand. Thank you for guiding us through that deep dive today. And thank you, our listeners, for joining us.